Here it's kind of morning. My name is Ronen Shechter. Thank you for having me. I'm in Baltimore at Johns Hopkins Hospital. I'm the acute pain service director here, and today I would like to share with you our experience here about building bridges with addiction medicine service to manage surgical pain and fight actually or assist in fighting the opioid crisis. Okay, I do not have any disclosures. Now, a little bit background about the state of opioid epidemic in the epidemic in the United States. As you know, in 2016-17, it was considered as an epidemic. A lot of funds has been given to that to fight that. However, our success is not. We're not too successful in that, and actually, the number of overdose deaths from opioids has been increasing. In 2021, it has passed the 100,000 overdose death. This is during the COVID, of course. It is as a comparison has been more than how many basically died during Vietnam War, and it's very alarming. If we're looking in more details, what basically are the opioids which led to this crisis or increasing it, is basically synthetic opioid, which is very, very easy to access and is very cheap, unfortunately. And here in Baltimore, if you drive, you'll see it in many corners, homeless and people standing to get some money, and with very little money they can get the next dose, unfortunately, and many of them get injured. If looking in Baltimore City, where our hospital is located, in 2018, more than 800 people died from overdose, and this is 5 times more than in 2011. And more than 90% of fatal overdoses were related to opioids. Now, Baltimore is the highest age-adjusted overdose fatality rate of any U.S. city. And about 1 in 3 of these overdoses are happening in East Baltimore, where basically Johns Hopkins Hospital is located. Now, at Johns Hopkins Hospital, there has been an increase in hospitalized patients with a diagnosis of substance use disorder, and 13% of hospital discharge had a substance use disorder diagnosed in 2018. And this has increased to more than 20% in 2020, means every 1 of 5 patients basically has this diagnosis in our hospital. Now, a little bit background about substance use disorder. It, as you know, it's a treatable, chronic, relapsing disease in which substance use is associated with impaired control, social impairment, risky use, and withdrawal tolerance. The morbidity associated with it are trauma, suicide, homelessness, and all the things that comes with that, and infection, if it's HIV, HCV, if it's skin or soft tissue infection, osteomyelitis, endocarditis. And basically, that's why we see them in the hospital, because they're coming after trauma, or after they got injured or gunshot wound, or if they coming with infection in limb, after popping or injecting there with an infected syringe or whatever they're unfortunately using. The Diagnostic and Statistical Manual 5 has 11 criteria to come with the diagnosis of opioid use disorder. The more positive criteria we have, the more severe is the condition. 2 of them, the tolerance and withdrawal, are not counted in case that patients are under care of a provider. Now, when we're treating opioid use disorder, the things that are important are medications, which include the methadone, buprenorphine, and naltrexone. I'll speak more about the buprenorphine specifically because it's a more complex medication. In addition, the treatment is psychosocial, behavioral treatment, as well as community-based peer support. The American Society of Addiction Medicine has level of care, which starts from an office-based opioid treatment to outpatient treatment with or without supportive housing, then going to intensive outpatient treatment. And of course, there is also the residential inpatient treatment. The American Society of Addiction Medicine criteria is the most widely used and comprehensive set of guidelines for placement, continued stay, transfer, or discharge of patient with addiction. And as you can see in this slide, this comes from their website. It starts from an outpatient going to intensive outpatient to inpatient and then intensive inpatient. And in each one of them, there are a few kinds of treatment options. Now, as mentioned before, we, or Johns Hopkins Acute Pain Service, has been treating an increasing number of patients who suffer from substance use disorder. The Acute Pain Service managed surgical pain with a limited focus on their addiction, basically. This has led to suboptimal pain control. We missed substance use disorder diagnosis and basically recovery opportunities of these patients, as well as we put this patient at increased risk to overdose death upon discharge. And this happened because we treated their pain, but we treated them with less opioids than what they were used to use on the street. And when they leave the hospital, they went back to the same dose they used to use before admission. And basically, as their tolerance has decreased, they overdose themselves. Now, to address the increasing needs for inpatient addiction services at our hospital, a new inpatient addiction medicine consultation service was established in July 2020. As a result, both addiction consult service as well as acute pain service jointly were managing these patients with a diagnosis of substance use disorder. And traditionally, we, acute pain service, focused on managing acute perioperative pain, and addiction consult were focusing on managing their addiction. Now, at times, because of that, the plans were incoherent. And subsequently, the APS and the addiction services have shifted into collaborative, comprehensive management. And our efforts have led to remarkable improvement, at least in our communication with each other, as well as in all aspects of care for these perioperative patients, so painful patients, actually. Now, the potential challenges that we encounter working together is unknown tolerance, which makes it very difficult to know how much opioids actually these patients require to manage the pain, as well as avoiding withdrawals. And we will not always agree about what we think. In addition, initiating or continuing buprenorphine is always a challenge and should be considered and planned very well in order to be successful, to be able to manage the pain, as well as avoiding withdrawal. Opioid use disorder medication, which I mentioned earlier, the buprenorphine, methadone, and naltrexone, were clearly managed by addiction team, though who managed the rest of the opioids was not always very, very clear. So we had to decide who does that. In addition, coordinating the post-discharge opioid management and pain management was often very challenging. Now, the potential positive collaboration outcome were saving lives by initiating the opioid use disorder medications, having better pain control, hopefully, and we always call financial incentive, also possibly shorter hospital stay. So if we're speaking about saving life, it's known based on multiple references that treatment of opioid use disorder with methadone, buprenorphine reduces risk of both all-cause and overdose-related mortality. In addition, a hospital or emergency department initiated buprenorphine was associated or is associated with low rate of other opioid use comorbidities, as well as increased engagement. Now, this treatment is associated with decreased morbidity, which reflects as lower rates of other opioid use, improved social functioning, decreased injection drug use, reduced risk of infection, as well as improved quality of life. So the first friction we had between the new established service and the acute pain service was around buprenorphine. Now, some background about buprenorphine. Buprenorphine is an opioid used to treat opioid use disorder, as well as acute pain and chronic pain. Buprenorphine was patented in 1965 and approved for medical use in the United States in 1981. Now, it is available in multiple formulation. It can be delivered sublingual, in buccal. It can be injected intravenously or subcutaneously. It can be delivered as skin patch, which is usually for chronic pain, which is a lower dose, or it can be also implanted onto the skin. Some of the formulation will come with naloxone to decrease the abuse potential of these medications as well. Now, what's interesting about this medication is its pharmacodynamics. The pharmacodynamics-wise, buprenorphine has a very high affinity to the mu opioid receptors, which explains its 40 to 70 times higher potency compared to morphine. However, it does not translate in having better analgesic properties because it is partial agonist. Now, a nice analogy when I'm thinking about opioids and pain is to think about pain as darkness and opioid and pain relief as light. So when patient is in a lot of pain, he's in the darkness, and then in order to treat their pain, the darkness, you need to turn on lights in their body. And this light basically the outcome of what activation of opioid receptor causes. And there are many switches in our body which are basically the opioid receptors. And depends what basically turns on the light defines what light intensity you're actually getting from this activating this receptor. So when a full agonist such as morphine, dilaudid, oxy, etc., when you switch one switch, basically you get a full bright light. But when buprenorphine switches this switch on, you're getting very dim light. So the reason, basically what it does, because of the high potency, if I take the same amount of opioid, let's say I'm taking 1 milligram buprenorphine, I will have 40 to 70 more receptors activated, but all of them will be dim light compared to one light turned on by the same dose of opioid that turn on the switch. So it's not very clear whether 40 or let's say 50 times more lights, dim light is turned on, creates more brightness than one light turned on by the full agonist. So that's why the high potency is just how many receptors activated by the outcome of the analgesia is not necessarily more. So we don't actually know how much analgesia we're getting from it, but it is analgesic and it can help treat pain. In other receptors like the kappa and delta opioid receptor, it also has very high affinity, but it is an antagonist. But we will focus just on the mu receptor. Now, two problems that we have with buprenorphine around time of surgery is withdrawals. And actually, if we have buprenorphine on board, we're blocking the receptors from full agonists that we want to give the patient, and basically decreasing the pain relief after surgery or painful condition that we can provide them with opioid. Now, if you're looking, try to put my cursor here. If we're looking here on the graph, we can see this is the red line in the middle. This is what buprenorphine does with increasing dose. And basically, the response to buprenorphine regarding the withdrawal depends on the level of opioid receptor activation by other opioids at the time that we give the buprenorphine. For an example, if we have a patient that comes after abusing, let's say, heroin, and he doesn't have any more heroin, and he goes to withdrawals. So basically, he ends up here below what buprenorphine will cause. So when we give them buprenorphine, we're actually treating the withdrawal. But let's look on another way. Let's say a patient is in a lot of pain and getting lots of opioids after surgery, and then we want to introduce buprenorphine. Basically, we're here, and buprenorphine will push us down here, leading to the withdrawals. Now, if we speak about withdrawals, usually it starts about 5 to 12 hours after after not having short-acting opioids, and can be up to 32 hours to start up to 32 hours after longer-acting opioids. The peak is about 48 to 72 hours and can last up to 4 to 6 days. The symptoms can be as listed here, and we have the COWS as a tool with 11-item scale, including objective and subjective data. And again, the higher or more positive symptoms we have, the higher the score is, means the patient is more going through withdrawal. And this is important when we initiate buprenorphine. So managing withdrawal, of course, giving opioids will help that, because you're basically reversing or activating the opioid receptors. But also we have adjunctive therapies, which include the listed here, to treat different variety of symptoms that the patient may experience. Now, things to consider when we initiate buprenorphine or when we're treating buprenorphine. Number one, when dealing with buprenorphine, we need to consider whether this is a painful or non-painful situation, which basically tells us if the patient needs opioid or analgesic or not. And the other thing to consider, whether we are already on some buprenorphine and coming to the hospital, and we need to decide if we change the dose, that the patient has been on that already, or we actually initiating a treatment for, let's say, a patient that has been abusing and interested to be to recover and interested to start buprenorphine. So perioperative period is painful. So this is one side. So a patient comes and we know they'll be in pain. And as a result, that we have, as I mentioned, two situations. If we need to change stable dose, we have to decide what to do. The concern is that if we keep giving the same buprenorphine, we theoretically can prevent managing their pain optimally or effectively, because the buprenorphine is high affinity, will not allow any other opioids to manage their pain. For that reason, like until a few years back, we had many pathway and protocols we've been using, but our goal, this is one that came from University of Michigan, and it was well accepted. And they even said that if a patient comes for a painful surgery and they still took their buprenorphine, they would consider canceling the surgery. Well, it has been a practice, but we learned one thing, that it has increased the relapse rate, because these patients actually were hooked up to full agonist opioids, and then it was very difficult to reintroduce buprenorphine, and then went into full-blown addiction. So as a result, the American Society of Regional Anesthesia published in 2021 an expert panel recommendation. Now, I must emphasize that this is an expert panel recommendation and not based on a lot of data or a lot of studies. And basically what they said, the opposite way. They said if patient comes in pain, we need, of course, to treat them with non-pharmacological management and non-opioid pharmacological management. But if we speak about buprenorphine, interestingly, they said not to stop, even not to decrease. They said to increase the dose. Now, this is my personal opinion, and I'll tell you. I think that the panel, the expert panel, the purpose of it was to be as broad as possible and to be applied in all settings. In addition, the concern from the relapse is so high that the recommendation focus on preventing it, even in the price of more pain. I personally see on the floors that sometimes patients doing well when increased, sometimes doing very poorly. So I think that likely the truth is in between somewhere. So, and it's every patient is different, so we have to decide. And this is actually one project that we are thinking to do as with addiction medicine, is to study it and to see which approach is better. Should we really increase? Should we keep? Or maybe we should sometimes decrease a little bit. But again, this expert panel recommendation is meant to be used as broad as possible, and again, to be applied in every hospital and every place. No, and again, not every hospital would have the privilege to have acute pain service, to have addiction service. So this is the safest way. This is the safest approach to decrease the relapse rate in this patient. Now, if we're speaking, until now we spoke painful situation when they are already on buprenorphine, but if we're speaking about initiating treatment, this is a different story. And again, I put the slide on with a cursor to that side. So this is again comes from the expert guidelines, and you can review by yourself the guidelines, the expert recommendation, but basically what they're saying is to rely on withdrawals. Basically what they're waiting that the patient will go through signs of withdrawal, so they'll go below this line, then slowly introduce buprenorphine, because we don't want them to have withdrawals when we're initiating this medication. When we initiate medication with withdrawal, they have very bad experience and less likely they would like to continue on this medication. So basically what they're waiting that if the patient is on a PCA, which is an IV opioid or oral opioids, is to basically wait a few hours to see that they're going through withdrawals, and then give them a small dose of buprenorphine and slowly introduce it. However, this is not possible when there is a lot of pain, and basically patient cannot even tolerate a few hours of not having any pain treatment. So what do we do in this situation when patient would like to be stopped? And for that, we need the addiction service colleagues. So basically that's what we're using, the low dose initiation or microdosing. And in this way to introduce buprenorphine for the first time is to give small doses and up doses. Start with 0.15 IV and then 0.3, 0.6, going very gradual, but at the same time, they providing a lot of opioids in the background to prevent withdrawals. Now, this has been very successful. The patient basically with this system can still get the full agonist opioids while we introducing gradually and slowly buprenorphine. And again, this can be done mostly as an inpatient, though there are also some reports of using the patches, the Butron patches, or initiating that as an outpatient, while patient is still using full agonist opioid.
Dr. Ronen, I'm sorry to interrupt you, but we cannot see your slides anymore. We can't see the presentation.
All right, thank you.
Oh, I just meant we cannot see the slides anymore. If you wanted to if you wanted to share it again so we can see it.
Just now happened? Does it just happen now?
Okay, yeah, a few moments ago.
Okay. Let's see. Do you see anything now? No? Okay.
No. We can
Okay,
see.
let me try again. Sorry. Okay. Let's go to the Zoom. Let me decrease that. Go back to the Zoom meeting. And right. Meeting. Okay, I see you. So let me share again. Here. There. Do you see now anything? My screen?
It's starting to share.
Yes, I started, right? Okay.
Yes, but we can see the screen of your computer. We cannot see the slides.
Yes, yes. I'm trying to fix it. Out. Mm. Remote. Mm. Mm. Then. Mm. Flip. Trying to flip the screens and where is this? Let me try again. Don't know what the problem is. Pause sharing for a second. Into the meeting. Happened. Let's do the other way. What I'll do is share the other screen and I'll try that way. I don't have way to get to that one, so I'll do this. Lets me do that.
Okay, now we can see it.
Yes, okay. All right, we're back. So you see the whole screen, right? All right, good. So now until now, I spoke about painful situations and what do we do if patient is already on buprenorphine, and what do we do if we need to initiate? Now, if we speak about non-painful situation when patient does not require opioids to manage pain. For an example, a patient comes in with recent heroin abuse and is not in pain, and he needs and he's interested to start buprenorphine. At this point, what happens? The patient start developing withdrawals, and what we're using basically the withdrawals again. We're using the withdrawals. So we're waiting for them to wind down the whatever the abuse, going below the red line here, and then we start initiating the buprenorphine. Basically, like what has been done with the acute pain when we wait until the short-acting opioids wind down, and then we can start it. So this is one protocol from the Substance Abuse and Mental Health Service Administration, but there are many different kind of protocols that can be followed, how to initiate the buprenorphine in this situation. And again, of course, if they're not in any pain, and in case they're on buprenorphine, we don't need really to change anything because there is no concern that the pain will be difficult to manage if we continue the buprenorphine. Now, if we speak about methadone, the other one which everybody speaks about, methadone as a full agonist does not usually pose any problems and will not trigger any withdrawal, and actually treating pain even more effective than any other opioid. It can get up to 10 times or more, like 100 times more potent than any other opioid. And the higher dose methadone you give, the more potent it becomes. This is not a problem, but not all the patients are interested to be initiated on methadone. Now, so now we spoke about the buprenorphine. Now, another challenge from the collaboration was who will manage the opioids. Now, it was clear that the addiction team manages the opioid use disorder medications, and that the multimodal analgesia such as ketamine drips, lidocaine drips, including regional anesthesia, was managed by us, by acute pain service. Now, the team decided really early that opioid will be managed by the first consulted service, because the primary team, the surgical team, will consult one service and then later on, and not always. And even if they consulted both of us at the same time, one service will come and see the patient before the other. So basically, this way we avoided disagreement and actually allowed us to learn from the other team. We could see what they did and they can see what we did. And basically we learned from each other what happens with different approaches. Now, basically this led that today, after about 2 years after we started working together, both teams are usually in agreement. We don't have much gap between what we think the patient needs regarding opioids. Now, discharge plans are very important. Now, this provides hope and continuation of care for both pain and addiction. Now, the addiction team assists this patient with post-discharge addiction care follow-ups at the appropriate setting based on their needs. Now, regarding their opioids for pain management, if addiction is managed by addiction specialists, we have a program, the personalized pain program, that is linked to acute pain service, and we follow our patients after surgery. Basically, we see them at the clinic, and we address the pain with multimodal analgesic regimen, including opioids. And again, this is only if the patient are stable or at least in the path to recover. If the patient is still going and abusing street drugs, we cannot really help them. It's unsafe to provide them opioids, but only if the patient are really stable and motivated and follow up with addiction medicine. Now, the goal of the personalized pain program is to optimize the pain, facilitate their recovery, while winning down and off their opioids with, of course, close monitoring for abuse. So this patient would have a plan. What happens the day after they leave the hospital, and not like it has been in the past, when they will leave the hospital basically with few pain medications, and guess what? They would go and buy the next dose in the street because they need to manage the pain, and no one addressed any of their addiction needs. Now, to quantify the impact of the multidisciplinary collaboration that I just described, these days we compare various outcomes in the opioid use disorder patient population prior to the introduction of the addiction inpatient consult service and after. Now, we believe that the collaboration has brought short and long positive outcome, including saving lives of this underserved and undertreated patient population, and the result will be published soon. Now, if you summarize, we can say that addiction and acute pain services collaboration is very important, though can lead to tension and incoherent care. And for that reason, coordinating care collaboratively is crucial. Each team learns from the other, and over time, this leads to coherent treatment plan that combines and optimizes care to address both pain and addiction. And last, this multidisciplinary collaborative care improves outcome and positive save life by providing the support that this patient population needs during their hospital stay and after a discharge. Right. Thank you for your patience, and if you're interested to learn more, please don't hesitate and contact me. This is my email. And,